Elimination of Medicare and Medicaid inefficiencies. That's not in there anywhere, but let me just horrify you with a story. There's been some wonderful work that's been done at Dartmouth Medical School by Jack Wenberg and Elliot Fisher over the last 10 plus years. They have looked at Medicare spending for Medicare recipients over their entire Medicare lives. And they've arrayed that spending by Medicare service area from low cost to high cost. Turns out there are very different patterns. Also turns out that in the high cost areas, the high costs come because the patients for the same conditions are in the hospital longer and they have more readmissions. And there's no evidence that they get any better. Jack Wenberg made a fascinating calculation. He said if you take Portland, Oregon as sort of your benchmark low and compare Los Angeles to that, if you throttled back Los Angeles to the Portland level of care adjusted for relative cost differences, with the amount of money that was saved, the feds could buy every Medicare recipient in Los Angeles a 300 Series BMW. If you look at Miami versus Portland, Oregon, it's almost a Maserati. This has been well known. This was published in Health Affairs about 6 or 7 years ago. One of the reasons we're not a fan of the public option is that this has been in the face of policymakers for 6 or 7 years, well documented, well endorsed, but nobody's doing anything to say, let's throttle Miami back. Very disruptive, right? It would require closing down a bunch of hospitals or shutting a bunch of hospitals and moving a lot of specialists out. But that, I'll be cynical and say that might solve the primary care doc problem in Wyoming. Have to connect the dots there. But personal responsibility, we've talked about that, and transparency. Things we don't like. The top of the list is the public option. Here's why. The public option is a great sounding idea. It's a way of getting everybody in. All of us in this room, I think, would accept the fact that the federal government does not adequately fund Medicare or Medicaid. And that results in a cost shift to us. It's been estimated that the cost shift is on the order of 30%. So what we in the private insurance market pay for a room at a hospital is about 30% higher than it has to be because the hospital has to recover the cost of giving services to the it's so-called uncompensated and undercompensated care. We feel very strongly that given that predisposition, that it is very difficult to see how the feds will decide to fund a public option in any other way. In other words, they will underfund it. Now, if that happens, that's going to encourage small, middle, and even some large market companies to seriously consider, well, and that public option is going to be priced lower than private insurance is. That will encourage smaller companies and even some large companies to consider dropping their coverage and shifting their employees into the public plan. If that happens, there are fewer private insured people to whom costs can be shifted. And if you can imagine, if that continues to cycle, the cost shift gets ever and ever higher, which drives more and more privately insured people out of that plan. I'll give you an interesting example. In the House bill, I believe the pay-or-play rate is set at 8% of payroll. At Safeway, we currently pay 18% of payroll. How can we, as a shareholder-conscious employer, not at least consider saying, let's go public? Let's save 10 points. I can guarantee you a lot of other large employers will have that same internal thought. It's not a trivial conversation, it's not a trivial outcome, but it will be considered. If this cost shifting, rather if this shift continues, eventually there's no one left in the private insurance market to whom to shift. And at that point, the feds have to really wake up and say, my God, now we have to fund the full cost of care, or we have to ration, or we have to finally get serious about bending the cost curve, but we may be 10 years down the line by the time that happens. Those are not good options. We believe a public plan pretty much inexorably will lead to that. We don't believe small business should be excluded. Large companies are currently paying the cost of small businesses that are out. And food taxes, we just don't like sin taxes. We basically think that people ought to have free choice in this country, that they ought to have good information about their choices, and be responsible for the consequences. We've estimated some sources of funding, and by our best lights, it'll cost about $90 billion a year to insure the uninsured, and most people would come out with numbers somewhat like that. Ours are a little bit lower than most because we don't think the caliber of the plan has to be quite as high as some. We've then arrayed against that a series of sources of funds that are available. The first one was what we call private sector recovery. If you get everybody in, you no longer have the cost shift. So the rates that the hospitals are charging to the privately insured people are lower, and so much of that money comes back to private insurers in the terms of lower costs. We don't think it'll all come over. We think there'll be some shrinkage that'll be retained by the hospitals and doctors. We talked about transparency being important. Our best estimate is that's 15 or 16% of total costs, almost $200 billion a year. We talked about the Medicare Medicaid thing. As I said, 2 or 3 times more in Miami than in Portland. My best estimate of that is that there's $140 billion of excess money that could be taken out, not without some catastrophic repositioning in the Miamis of the world, but nonetheless the cost savings are potentially there. And then the use of HIPAA incentives at the 20% level, the 30% level under the Senate bills, and with possible discretion of the Secretary up to 50. Admittedly, those last 3 are short-term cost shifts, but long-term, if they drive healthier behaviors, they are absolute cost savings. Net, $434 billion. That's starting with a deficit of 88. So there's about $520 billion of annual savings available there from various sources, none of which has been tapped, with the possible exception of the $21 billion in HIPAA 30% under the Finance Committee and the Senate Health Committee. That's sort of 5 to 1 in terms of coverage. Even if you want to discount it enormously, we think there's a lot there that can be done. Just a final slide. This is a commercial. We formed a new company called Safeway Health. I'm spending most of my time in that now. Our quest is to partner with other companies to help them achieve the same things that we have. Our business model is shared. It's multi-year contracts and shared savings, so if we don't save money for you, we don't get paid. And I would be delighted to speak with any of you about how we might be able to help. And with that, I will say thank you very much.